Hi, this is Piyush Bhargava, and I have a couple of interesting cases to share with you. Our first patient is a 66-year-old male who presented with chest pain, and a CTP protocol was performed. I have one image here on the top right. The study was negative for PE, but there were multiple lung nodules seen and metastatic disease was suspected. One of these nodules was biopsied and they found undifferentiated cancer. Patient underwent a FDG PET-CT study. The whole body image is shown here. The lung nodules are hypermetabolic, and interestingly, we find a large hypermetabolic mass in the lower neck, which corresponds to this mass arising from the left lobe of thyroid. Patient next underwent a whole body scan using I-131, and on the anterior and posterior whole body images, we see that the metastatic disease in the chest does not take up radioactive iodine, and it's hard to figure out where the uptake is in the neck on the anterior image because of intense uptake and septal penetration, which we call a sunburst pattern or a starburst appearance. But on the posterior image, it's very clear that the uptake is in the right lobe of the thyroid, which is seen here. That's the normal right lobe of thyroid, and there is no uptake in this mass arising from the left lobe of thyroid. So the diagnosis here is an anaplastic thyroid cancer. These tumors are very rare and account for 1 to 2% of thyroid cancer, more common in females, and patients usually present in their 6th and 7th decade. Being an undifferentiated tumor, it's very aggressive. It's characterized by local invasion and metastatic disease, and frequently patients present with stage 4 disease. This has the worst prognosis of all thyroid cancers, with 5-year survival of only 5%. This cancer, anaplastic thyroid cancer, does not take up radioactive iodine, so whole body scans using radioactive iodine have no role in anaplastic thyroid cancer. FDG PET-CT is helpful for whole body staging and for follow-up. Our next patient is a 56-year-old male who presented with painless swelling of the left scrotum. They first underwent an ultrasound, which is shown here. There is a large heterogeneous mass seen in the left testicle, and they underwent a left-sided orchiectomy. Orchiectomy showed a primary testicular lymphoma, and so this patient underwent a FDG PET-CT study, and a whole body scan is shown here with multiple foci of increased uptake seen in this linear pattern extending along the gonadal vessels to the retroperitoneum and then involving the left kidney. The involvement of the kidney is better visualized on this fused PET-CT image, where we see hypermetabolic tissues surrounding the posterior aspect of the left kidney. Better visualized on this contrast-enhanced CT, we see this tumor in the perinephric space trying to invade the kidney and also involving the retroperitoneum. So this is a very interesting finding where there is direct or contiguous spread of the tumor, which here is a primary testicular lymphoma, along the gonadal vessels through the inguinal canal to the retroperitoneal space, with spread to retroperitoneal lymph nodes and to the perinephric space around the left kidney. So primary testicular lymphomas are also very rare, accounting for only 5% of testicular tumors and about 1 to 2% of all lymphomas. Most of them are diffuse large B-cell lymphomas. It is the most common testicular tumor in patients over 60 years of age. Patients typically present with painless swelling. This is the tumor that has the propensity to be bilateral, so we can see lesions in both testicles in up to 10% of the cases. Systemic disease is seen in up to 20 to 30% of the cases at the time of presentation, and most common metastatic site is the central nervous system. FDG PET-CT is used for whole body staging and restaging, and increased uptake of FDG means poorer prognosis. This tumor responds well to treatment, which is orchiectomy and chemotherapy, but it still has a poor prognosis with a 5-year survival of only 35%. Thanks for watching.